All right, here we go. Let's get through this stuff. All right, so we were talking about disorders of the SI joint last time, and the next up is pregnancy. How can pregnancy be a disorder, cause problems with the SI joints? Well, when you're about ready to give birth, like this lady is, you release hormones. One of such hormones is called relaxin, and just like the name implies, it loosens ligaments around the pelvis in particular. And so your SI joint is affected, your pubic symphysis is affected because the pelvis has to stretch way out to get this thing out, right? That's huge. So the pelvis has to stretch. So the hormone relaxin is responsible for that. But it also makes the SI joints very vulnerable to injury when the time gets closer and this ligament is relaxed. And in fact, some chiropractors, that's all they do is they specialize in pregnancy, trying to keep the SI joint in line and happy, and by using different supports and belts and things like that to help so they don't injure their SI joint. Okay, that's all we'll say about that. I do like these inflammatory diseases. Here's another one you're gonna have to take with you pretty much forever. These are a group of inflammatory disorders called the seronegative spondyloarthropathies. So make a note card on. You got to remember that word, and you have to remember who they are. All of these joints can cause inflammation of the SI joint, and if that occurs, pain can occur. So let's look at who the members. We'll look at the members in a second. All of these. Here's all the disorders. Don't write them down yet. We'll get to them, but all of these conditions have one thing in common. Most of the time, when you order labs, you order two important tests called rheumatoid factor and a HLA-B27 antibody. And I'd say 85 to 90% of the time, patients in this group will have a negative rheumatoid factor, so they'll test negative for this factor, but they'll be positive for the HLA-B27 antibody. In fact, it's so diagnostic of this group, they named it after them. So seronegative means rheumatoid factor negative, and the spondyloarthropathy is kind of the HLA-B27 positive part. That'll make more sense as you go through the program. But so all these seronegative spondyloarthropathy patients, when you get blood work, most of them will test positive for this HLA-B27, and you'll study that more as you go through the program. That's not a good one to have. And it's an antigen that hangs out on macrophages and monocytes and other cells that are defense type cells. And the rheumatoid factor was negative. So let's meet them. The king of all of these, I guarantee you'll have patients like this, are the ankylosing spondylitis patients. Who's heard of AS, ankylosing spondylitis? A couple people have. It's out there. It affects people your age is the group who gets this first. It loves the SI joints. In fact, it's the number one target of AS. Another one we'll talk about in fifth quarter are the intropathic arthropathies. So that sounds foreign to you, I know, but how about Crohn's disease? Who's heard of Crohn's disease? Everybody's heard of that. And ulcerative colitis? Everybody's heard of ulcerative colitis. These diseases usually affect the intestines and the small bowel. They cause bloody diarrhea, stomach upset, all kinds of intestinal problems. About 20 to 30% of people with these conditions, with Crohn's and ulcerative colitis, it also attacks the joints of the body. And it can be a vicious attack. So not only do they have bowel problems, stomach upset, they also get their joints destroyed by an autoimmune type attack. That's called an extraintestinal manifestation of these Crohn's disease or ulcerative colitis. So we'll talk about that more in fifth quarter. So inflammatory bowel disease is a member of the seronegative spondyloarthropathy group. Psoriatic arthritis, the golfer, the lefty, Phil Nicholson? He's got psoriatic arthritis. He functions at a very high level with taking really heavy-duty anti-inflammatories to keep it under control, specifically anti-inflammatories that attack tumor necrosis factor alpha, which is the king of the anti-inflammatory gang. It's a cytokine. And psoriatic arthritis, who's heard of psoriasis? Yeah, that's another really common one. So a certain percentage of people with psoriatic arthritis get psoriasis. It's really the other way around. More people have psoriasis, skin disorders, which I just talked about 2 hours ago in 7th quarter. But a certain percentage, about 20-30% of people with psoriasis, they can have the same thing where the same condition attacks the joints and it can rip the joints to pieces. It can be very disabling. So that's, and these patients also test negative for Rh factor, positive for HLA-B27. Reactive arthritis is the new word for this. We used to call it Reiter's syndrome for many, many years. Pencil in a cup type destruction, and you'll understand what that means later on, but that's still a strong AKA. These two are pretty rare, Whipple's disease and Beckett's disease. They're members as well, but they're pretty darn rare. I've never even seen a case of either of those. I've been doing this for many, many, many years. All right, so what else do these seronegative spondyloarthropathies have in common? The mnemonic is I pain, I'm in pain. And this is how the patient will come into your office and how they'll present. They have an insidious onset of low back pain. What's that mean, insidious?
Doesn't go away.
Not it doesn't go away. There's no cause. They can't think of a cause. It's like, I've been thinking and I don't know why it happened. Just slowly started to come on. That's insidious. There's no like big smoking gun, like I slipped and fell on the cement. So insidious, a slow, kind of mysterious onset of back pain and SI joint pain. The pain also tends to be worse in the nighttime, especially in the morning. They get up and they feel terrible. But as the day goes on, the pain decreases, and they're not really feeling that bad before bedtime. But then the whole cycle starts again. And the age of these people is quite young. It's under 40. It's 30 people in the 30s and 20s is where this starts to show up. It can improve with exercise. It can make it feel better, not like crazy, deadlifting and power cleans, and like just easy exercise. It can feel better with. One weird thing is it doesn't get better with rest. Run-of-the-mill arthritis, degenerative disease, that always feels better when you're resting. But this one doesn't improve with rest, which is kind of strange of it. So those are the clinical presentations. Eye pain. So make sure you know that. A case study, 32-year-old male comes in, 6-month history of progressive stiffness in the back, worse in the morning. Your little antenna should pop up. Ooh, ankylosing spondylitis could be one of those cases. He's 32. It's unusual for someone to have this presentation. It was an insidious onset of pain. There's no real incident. The pain seems to get better as the day goes on. This is a true case, by the way. Ordered blood work. Sure enough, Rh factor is negative, and he's positive for HLA-B27. So I'm immediately thinking, it's one of the seronegative spondyloarthropathies. It doesn't have to be, but it's pointing that direction. You take x-rays. Let's look at some x-rays. So here's normal to refresh your x-ray brains. There's the SI joints. Remember we said they're all weird looking because they angle like this. So they get flattened so you can see many different planes within the joint. But the key is to look for super whiteness around the edges of these joints. That's normal. Now look at our patient. Can you see what's happened? Look at how white that is. So that's an inflammation within the bone that's going on there. So that's classic of ankylosing spondylitis in particular. Other inflammatory diseases in that seronegative spondyloarthropathy family can do the same thing. But when you see the SI joints, you immediately think of ankylosing spondylitis. And yeah, so if there's a blow up of the joint, it's pretty much destroyed already at such a young age. And he did have ankylosing spondylitis. More testing revealed that. So kind of a bummer. Here's another case. Let's see, when was this one done? This was a couple of years ago. 72-year-old came in, chronic low back pain, scoliosis, which was surgically corrected with a really long fusion construct. Complains of moderate pain, severe stiffness. In the morning, had low back pain and the bilateral SI joint pain. Exercise seemed to help. Ordered blood work, same story. HLA-B27 positive, rheumatoid factor was negative. Here's a CT scan of the patient. This is normal, just to refresh your memory, a normal CT cut. So we can see the vertebral body. We can see the space where the disc is. If you hallucinate a little bit, you can even see the back of the disc right here. Because you can, on CT, you can see a little bit of the disc. You have to practice hallucinating though. But you can definitely see the disc spaces. There's no bone out here. There's nothing white. And remember, bone stops photons, so not as many photons hit the X-ray plate, and it makes it white in appearance. Now if we look at our patient, you can see the pedicle screws, but look out front. Anybody see anything weird out front? What the heck is that? We don't see that over here, right? There's just some shadow, a little bit of disc shadow. There's bone here, so this patient has calcification of the anterior longitudinal ligament. It's thickened like crazy. So this is called bamboo spine, and it's classic of ankylosing spondylitis. Bamboo spine. And if the ligament gets thick, they start to get really stiff and lose range of motion. So they had ankylosing spondylitis. All right, there's a kind of the answer to the question. Posterior longitudinal ligaments, not, you can't really see it. That runs back here. We'll talk about those in lab today, actually. But the anterior really gets bad. All right. What else can cause SI joint pain? It could be an infection. This doesn't, in our country, you don't see this as much. It can happen. I've seen a couple of cases like this, but my practice is made up of crazy cases to begin with. You probably won't see one, but you never know. So you can get bugs that invade the SI joint, like Staph aureus bacteria that Dr. Doe will teach you all about. Very destructive and very hard to get rid of this bug. It loves to get into the SI joint if it can get into the area. Where does it come from? On older people, sometimes they get an inflammation of the heart called bacterial endocarditis, which is an inflammation of the endocardium of the heart. Typically, it happens after a dental procedure where they're doing like a root canal, or there's a lot of blood that's released in the mouth, and the mouth is absolutely filthy, right? When it comes to bugs, there's all kinds of bacteria in there. You don't want those bugs to get into the blood. But in older people, sometimes their immune system isn't strong. The bugs get in there, and they get stuck in the heart, and they kind of take root, start multiplying, and you got yourself a invasion of the heart. The body's immune system sees it, attacks it, and now you got an inflammation. And some of those bugs can get into the bloodstream after they've kind of grown in the heart, and they, for whatever reason, they like to stick in the SI joints, and you can get an infection, kind of a bug infection of the SI joint. Not in our country, tuberculosis, that's a menacing bacteria. That thing, you'll study that more with Dr. Doe. But that also can get into the blood and get into the SI joints and cause an inflammation as well. And the body does not, once it spots the bug in the SI joints, it mounts a wicked inflammation to kill the bug, which is awesome. But the trouble is when it kills the bug, there's collateral damage. You guys know what superoxide is? Some of those radical oxygen species, nasty superoxide. It gets released and it kills the bug, but it kills the tissue of the joint itself. One of the many kind of destructive agents that's released. Fifth quarter, we'll talk about that more. And this is a really good medical book, and they have our bread and butter here, subluxation. A subluxation of the SI joint. I was shocked to see this because usually they don't. The older medical docs, they don't like chiropractors so much usually. But this is our bread and butter. We treat subluxations, and that's where the joint gets stuck and doesn't move anymore. And sure enough, it can mess up biomechanics. So if your SI joint gets stuck, we said there's about 2 degrees of nutational motion. If it gets stuck and stops moving, who's going to take the stress of axial load passing through that joint? The ligaments in the back, the interosseous posterior sacroiliac ligaments, they get overworked. Normally the joint takes that little movement, like you're bending and you're twisting and you're doing things, and the joints are moving a little bit to absorb that. If they're frozen together, that motion or that force has to go somewhere, and it goes backwards into those interosseous sacroiliac ligaments. And you get an overuse syndrome. It causes an inflammation of those joints. Here's an overhead view. We've looked at this. There's our SI joint right there. There's our interosseous sacroiliac ligaments back there, very strong. But if that gets fixated and these things start taking too much load and too much movement, they're not designed to do that. You can get an inflammation started. Very difficult to snuff that inflammation out. A lot of times you have to do cortisone injections to get that. Because you can't really, well, I guess you could put a body cast on them, I guess, and stop the movement, but tennis elbow or something, you just put a brace on and fix them, but it's a tough joint to block and stop the motion in, so. Yep, so fixation can definitely do it. Well, I guess this is pathology day. I thought I took this out, but here it is. Let's look at it. This was a crazy case. This is last year. So we have a 59-year-old male. He had a failed interbody fusion. He's not from our country. And so he comes to me, and the first thing I look at, the surgeon fused L2, L3, L3, L4, L4, L5, but they ignored the sacroiliac joints. And then I looked at the sacroiliac joints on a CT, and I always say, I bet my first quarter students, somebody can see. Does that look right to you? That looks terrible, right? There's a huge bone spur that's actually welded this joint together. And here's another bone spur that almost has welded this one together. So I ordered intra-articular SI joint blocks. My pain doc guy stuck a needle in there and filled it up with lidocaine. Pain went away, a miracle. But it came back in about 5 hours. But that's what the test is for. So we proved that the SI joints were the problem. The surgeon should have known that you don't do a big fusion like this without fusing the SI joints too, or you're just asking for trouble. The reason it failed, this probably wasn't even the problem. If they would have started down here, they maybe could have avoided a big fusion. So he tried steroid injection, which didn't last. So he's going to get a fusion of the SI joints and connect it to the construct here. Hopefully that will help him because he can't work. He's so disabled. All right, what else can cause trouble? Who's heard of gout? Everybody's heard of gout, right? Gout is a condition where you get a buildup of uric acid, especially if you eat red meat, and there's some types of meat are worse than others, and you get a buildup of uric acid, and those little crystals, the uric acid can crystallize in joints, and for whatever reason, it loves the metatarsal phalangeal joint here of the big toe. And it's like a little ground up glass inside your joint, and it hurts, and it causes a wicked inflammation because the body recognizes it's not supposed to be there and it's damaging tissue, so you get a rip-roaring inflammation and a joint filled up with uric acid crystals. Occasionally those uric acid crystals can deposit in the sacroiliac joints and make them hurt as well. It doesn't happen that often, but it is one of the possibilities for sacroiliac problems. Hopefully you won't see these in your career. I've seen these every now and then. Sometimes, I've never seen one of these. There's 2 ways you can get cancer of any part of your body, your breast, your prostate, your SI joint. It can either grow there, which would be a primary tumor if it grows in the SI joint and cause trouble, or it can come from somewhere else, like You have prostate cancer. The cancer cells, as they get more and more dysblastic, more cancerous, they detach. They don't like to hang around people anymore, and they like to be free, and they like to invade the lymphatic system and be set free in the body. And these primary cancer cells get into the bloodstream, and they can go anywhere and stick. And they can stick in the SI joint. Prostate cancer patients are the ones I've seen where they've had prostate cancer, and the cancer got out of the prostate into the body lymph system and ended up in the SI joints. If the cancer cells get in the SI joints, the body is going to spot them and mount a wicked inflammatory attack against those cells, and the inflammation is going to set off pain receptors. You're going to have a lot of pain in the SI joints. So cancer can potentially get into the SI joints, and it can get into other places. Prostate cancer usually goes into the lumbar spine. It's its favorite target, but it can get into the SI joints. It can get into the femur. It likes the lungs, and you'll learn. You don't have to know that now, but you will eventually have to learn that, where it likes to go. So cancer can also be a rare cause of SI joint pain. What is the prevalence? What does that even mean, though, prevalence? What's prevalence? Because you've heard of prevalence and you've heard of incidence. So prevalence starts with a P. I always think population. So prevalence is what part of the population is walking around right now with whatever disease you're thinking about. So population. So what's the population count of people with chronic SI joint pain? This is very interesting here. There's a place called SI Bone, which manufactures the medical instrumentation that's used to fuse the SI joint. They're in business by surgeons fusing SI joints. They have a huge research department. They tried to get me to work for them actually one time. I just wouldn't do it. And I saw my website, and they're like, why don't you have SI problems on your website very much? And I said, well, really, they don't happen very much. I think that made them mad. But their research, where their researchers who work for them, who are paid for by them, they came up with 25% of all chronic back pain is because of an SI joint problem. That's ridiculous, right? That's the kind of the fox in the hen house type of thing. Kramer, and I've written him emails, he won't change this. In Kramer's book, he says the prevalence of SI joint pain as a cause of chronic back pain is 50% of patients. That's outrageous. That's just absolutely ridiculous. If you look at the good research, and there's this DeFilippo paper, it's probably where it really is. They found in a study of 1,000 patients that 4.5% have SI joint pain. Newton was 10%, Murakami is 11%. So it's probably around in here somewhere to 5 to 10% at the most. It's certainly not 25%. And 50% is absolutely insane. It's a very strong joint. It's only got 2 millimeters of movement. It's pretty hard to hurt that joint. So prevalence is about 8.5%. Shame, scolding. I didn't have my Game of Thrones. Usually I have my Game of Thrones, the walk of shame. You'll see that in the fifth quarter. So third place. So what are the common causes of low back pain according to good research? I think we've said this before. Number one cause of pain over 6, and this is not a muscle pain, this is pain that's been there for 6 months and won't go away. A tear within the disc, the annulus fibrosis of the disc is number one. Close behind is a facet joint dysfunction or a Z joint dysfunction where there's inflammation in the joint and it's not working. That's our bread and butter right there. So we got plenty of patients to treat. Number 3 is the SI joint. We should talk about facet tropism a little bit. I think we have a little bit, but let's officially talk about it. It can be seen anywhere, but it's commonly seen at L5 and S1, that superior articular process of S1. We said normally facets are about 30 degrees as viewed from a axial plane. They should be the same. So they're about like, this is perfectly flat. So this is sagittal, that's coronal. So they're tilted about like, let's say, about like this is the normal plane of those joints. You're going to see some craziness here in a second. So, well, what will you tell me? How does that look to you? They're not even close to normal, are they? They're asymmetrical. So how are the forces going to go through the body here? They're going to be a little off, right? One of these joints is going to be, usually this one, it's too coronal. Usually this one becomes irritated, can be a source of pain. Yeah, it's a cause of a chronic back pain. Not all the time though. Some people can have this, especially younger people, and it hasn't caught up with them yet. But with the passage of time, this thing will get more and more and more degenerated. So here's another one. 53-year-old came in. Initial treatment had failed. What do you see on this one? It's the same thing. It's even worse. There's the supraarticular process. There's the inferior articular process on this cut. There's the spinous process. And look at these. That one's okay. It's about 30 degrees, but that one's way too sagittal, and it's got a weird little dip here. So those are chronic. This Facet Tropism is a chronic cause of low back pain. Right, so that's everything I said already. Yeah, and the ultimate treatment. I mean, if you guys can't fix it, you always start with conservative care first. If you can't fix it, you can send them to your pain management doc. They can do a study called a rhizotomy, where they burn the medial branches. Sometimes that works really good, but they tend to grow back. And ultimately, you have to fuse those joints together so they don't move at all. And that's what's accomplished in an inner body fusion, like Tiger Woods had. Okay. Another problem here, if a patient has two of these that are too much sagittal, these things can slip as you grow older. Right now, if this person bends forward, this part of the bone, this is L4 property, the slingshot, that wants to slide or translate forward. It can't because it's blocked by the supraarticular process from below. But if both of them are like this, it doesn't do a very good job of blocking. People, when they get over 50, can actually get a slip forward at spondylolisthesis because of this. And they can even get a unilateral slip. Maybe this guy, when he gets older, will start to have a slip here because there's not much stopping this thing from slipping forward. It's got this little lip right here, but that can break off with the passage of time. Okay. So that's called the degenerative spondylolisthesis. Here's an example of a patient with a degenerative spondylolisthesis, and you can clearly see the back of the vertebrae. They're not in very good alignment, are they? This guy's slipped way forward. There's the back of L5. L4 is way forward. Most of the time it's a fractured pars interarticularis, but if they're over 55, that's not the case. Let's look at this view, this overhead view of the disc. And you can see this is a normal, maybe 30 degrees here on these joints. There's no slip. Now let's look at that patient. So if you look here, here's that slingshot. You could draw it like this. But you can see the supraarticular process is way back here. There should be no gap right here. So same thing over here. The supraarticular process is way back here too far. So this whole posterior arch has slid forward, and it looks like that. And those can be big trouble. In fact, look at that facet joint. See any difference between this one and that one? This is a T2 weighted MRI that shows inflammation. Anything with water content shows bright white. So we got a wicked inflammation inside the facet joint. And that doesn't always mean that's inflammation, but it's a clue that, yeah, this guy's got facet joint pain. And then he's got sciatica as well. We won't get into all that, but there's compression here. This ligamentum flavum is thick, and it pinched off the traversing nerve root. But the point for this lecture is we've got a slip of the Z joints because they were not coronal enough. They were too sagittal. And that's called a degenerative spondylolisthesis. Is a degenerative spondylolisthesis a break? Is anything broken? No, it's slipped. Is an isthmic spondylolisthesis anything broken? We've talked about that before. Where you get a fracture of the pars. We've looked at a CT of that. That's a fracture. And that's the most common type of spondylo. All right. Let's see. Everybody's squirming already. Let's do this. Well, we can do this tomorrow. You guys had enough? Or you want more information? No. Let's do it tomorrow. We'll cut it off right here. We'll pick it up tomorrow. So everybody good with the lab times and what we're doing? All right.